Welcome to this class on Neuroscience of Human Movement. Subthalamotomy was the approach to treat Parkinson's disease. So, essentially what happens is that the subthalamic nucleus is removed, right. This leads to reduction in inhibition, thus leading to an improvement in the motor function, right. So, Ldopa is essentially L3,4 dihydroxyphenylalanine, right. So, it is a precursor to dopamine, right. So, removal of a carboxyl group from this actually leads to the amine, that is dopamine. So, what happens is that when this is taken, this improves the amount of dopamine in the basal ganglia. So, importantly here you are not treating the disease, you are not treating the pathology, you are treating the symptom. So, this is used for symptomatic treatment of Parkinson's disease. So, essentially you are managing the symptoms, you are not treating the pathology. The pathology is degeneration of neurons in the substantia nigra pars compacta. It is not like taking levodopa is actually going to cause regeneration of these neurons in some sense, right. That is not going to happen. So, essentially also it does not even pause or stop neurodegeneration. Ldopa does not pause neurodegeneration, right. Unfortunately, early on in the disease this gives very good results and very satisfactory results, right. But later on in advanced stages the response of the patient to Ldopa is less and less. So, as the patient's pathology progresses, the ability of the patient to respond to Ldopa reduces, right. So, early on the patient responds well, but as the pathology progresses the patient is no longer able to respond well. Okay. Ldopa comes with its own side effects. Immediately after Ldopa intake there is hypotension, there is nausea, a lack of sleep, hallucinations. Also when the dose ends or when the time of the dosage ends, like it might be 12 hours in early cases and it might be lesser in later stages of the disease, what happens is there is a deterioration of motor function. So, essentially the motor function that was restored due to levodopa is now going back to its original state. So, which means that you have to take the next dose of the medication. So, this leads to a situation where the patient continues to depend on the medication for the motor function, but once again let us remember you are only managing the symptom, you are only treating the symptom, not the disease, not the pathology, right. The long term effect is that a resistance kind of situation wherein the same dosage only produces a lesser positive effect. So, early on the patient was able to manage with the medication for about 12 hours, later on the patient can only manage for much lesser. So, some sort of resistance like situation builds up. Then levodopa induced dyskinesias develop. So, it is a very unusual and very difficult problem, right. So, what is called as levodopa induced dyskinesias, right, or in short LID. So, this is a situation in which the patient, if he takes the levodopa, then he is going to have dyskinesias or unwanted movements. If he does not take the medication, then he has no movements whatsoever. Now, he has to choose between whether to have the medication and suffer its side effects or whether to not have the medication and suffer the pathology. So, there is no choice really, one kind of suffering will continue. So, this is an unfortunate situation that happens in the long term with the intake of levodopa, right. Also what happens is there is an amount of dysregulation of dopamine. So, essentially a resistance kind of situation develops later on, right, maybe due to multiple factors, maybe due to the role of receptors or maybe due to other factors, right. One alternative that has been suggested is deep brain stimulation. What this does is this implants pacemaker like devices deep inside the brain, specifically in the subthalamic nucleus for example, and so surgical implantation. So, these electrodes are embedded surgically deep inside the brain in the subthalamic nucleus, and like you are activating a pacemaker, this system is activated using say a battery, right. Now, this is known to improve motor function in patients, right. Actually, how exactly does this work? Now, that is not understood, which is why this approach is in general considered a very controversial approach. By the way, not every patient can take this, that is one. The physician only can make the decision on whether a patient is a suitable candidate for this. Not just that, since we do not understand how this works or why this works, right, because of that reason, because we do not understand how or why deep brain stimulation works, it is not clear which particular cases will result in what kind of improvements. So, that is continuing to be a case of trial and error type of improvement. A lot of information is now available, still there is not a clear understanding of how or why deep brain stimulation works, right. Several mechanisms have been proposed and speculated, and one is that there is PAC or pulse amplitude coupling in the brain between different regions. Now, deep brain stimulation essentially decouples this alpha and beta frequency waves in basal ganglia, inhibiting the gamma activity in the cortex, thus reducing the abnormal activity in the cortex and improving the possibility that the cortex can actually work in a more normal fashion. Now, that is probably the reason why deep brain stimulation is effective. These are just hypotheses, we actually do not know how or why deep brain stimulation works and why some patients respond better to deep brain stimulation than others, right. In general, this is considered better than Ldopa, and in general patients for whom Ldopa fails to function, right, are probable candidates for DBS. Of course, there are multiple reasons, there are multiple factors that are considered before making a decision on that. Of course, cost is a consideration, it is a very expensive procedure, it is a surgical procedure. So, the moment you say surgery, the cost associated with the surgery come into the picture. So, it is a more expensive procedure and it is a controversial procedure because we do not understand what is causing this positive effect, right. And also it turns out that a particular frequency, right, if it does not work, right, then the patient will have to go back to the doctor and the doctor will reset the frequency of the stimulation to something else that will actually work. Now, at that point it is not clear why the previous frequency did not work and the current frequency is now working. It is also not clear why the current frequency did not work earlier in the first attempt and why is it working now. A lot of confusion. So, which is why this procedure remains controversial. People are trying to understand the physiology behind this, the exact pathophysiology and the improvement due to this continues to be elusive for us. So, here is a X-ray picture showing the electrodes, the probe cores in projection on an X-ray. This is a frontal view. So there you see the implant. So that is the electrode, right. That is where you see in the lateral view. So that is where you see, right, bilaterally on both subthalamic nuclei, right. Well, the other approach is also controversial. We know that the neurons in the substantia nigra pars compacta degenerate or die, and so they cannot produce dopamine, right. Suppose you can implant these stem cells in the particular region and they can now produce dopamine, then this dopamine these dopaminergic neurons then communicate information, then it transmits signals. Then you essentially have a situation that is very similar to the natural system. Of course, many of these steps have to be crossed to reach that point. What are these steps? Essentially replace the damaged cell in the dopaminergic area with new cells. Let us remember that it may or may not halt neurodegeneration, most likely it is not going to halt neurodegeneration. An oversimplified version of the method is you have to extract the stem cell, right, and allow it to expand in number and differentiate them into particular type, into the dopaminergic type, and then implant them in the beach. Looks super simple, right, but very difficult to cross all these steps, and this particular this technology is not yet ready for use in humans. Very again also other problems come with this, like other than the fact that in DBS we do not understand the pathophysiology and why the pathophysiology, in what sense there is improvement, that is not understood. In this case there are also ethical concerns and other concerns that come with this. In general, whenever you say stem cell therapy, there is some concern that happens. It is still an open and hard area of research. Then the question is what is our future hope? So that means there is no hope. So Ldopa is going to work only for some time, and DBS is a controversial approach. We do not know why or how it works, and stem cell therapy is again a controversial approach. What is our hope? Well, physical activity or exercise has been hypothesized to have a neuroprotective effect. Very important to underline that. Essentially, neither Ldopa nor DBS nor stem cell therapy have a neuroprotective effect. It does not save the dying neurons, right. It is believed that physical activity or exercise can have a neuroprotective effect. The question is, in what sense is this a hypothesis? Because a hypothesis is a particular statement that can be disproved. How can you even disprove this? In that sense, it is very difficult to even consider this to be a hypothesis. Consider that the pathology is progressing at different rates in different patients. So essentially it is not like I can take two groups of people and ask one of them to exercise and leave the other without exercising, right. If you know that both of these people have, both of these groups have Parkinson's disease, why would you not ask the other group to exercise, or why would you ask the other group to not exercise, right. That is controversial. It is not just that, you can also identify groups of individuals who are predisposed to developing the pathology. Suppose I know this particular person is highly likely to develop Parkinson's disease, let us say based on family history, let us say based on genetics, let us say based on a whole bunch of analysis, I am able to predict, for example, that this person is highly likely to develop Parkinson's disease. Well, then again you do not know if the person will surely develop Parkinson's disease, then your advice is okay, go and exercise, and the chance that you will develop Parkinson's disease is going to reduce. Let us say that the person does not get Parkinson's disease. Is it because the person did not develop other symptoms, other situations that actually lead to the pathology, or is it because of exercise? In that sense, you actually cannot control that experiment. That is the problem. So, in what sense early detection of Parkinson's disease, let us say that we are having a device, a magical device that is going to help you detect the onset of Parkinson's disease much before the patient actually presents, right. I earlier said that about 80% of the pathway is already compromised, right. By the time the patient presents to the clinic, 80% of the dopaminergic pathway has been compromised. Suppose I could detect this early somehow, right. What can you do? It is not like you can start Ldopa early, because Ldopa shelf life is limited. It is going to work only for so many years, after that it is not going to work. Should you start Ldopa on these people earlier? Lot of confusions, right. So, will early detection of Parkinson's disease, is it going to help to postpone the debilitating symptoms by some more years if the person starts exercising? Right. Is it going to help, or is it that this person is having a slow progress anyway? Let us remember, different patients have different rates of progress, right. Not every patient is the same. So, because of this reason, you do not know to what extent a particular patient is getting helped by the pathology, right. So, should people at high risk for Parkinson's disease be screened, and should they be asked to start exercising? Well, everybody should start exercising, but is this going to actually work? Again, we do not know. What are the likely benefits, if at all? If at all there is going to be some benefit, what are those benefits? Again, that is not clear. So, essentially exercise and stem cell therapy and a deeper understanding of DBS offer some hope in therapeutic approaches towards treating Parkinson's disease, right. What we have seen in today's class is the therapeutic approaches towards treating Parkinson's disease. One is Ldopa or Ldopa, which is a pharmacological approach, and the other is a surgical approach, deep brain stimulation. It is a controversial approach, and the other is the stem cell therapy, again a controversial approach. Lot more research is needed before it can actually be used, and the other is of course exercise, but exercise can help everybody, not just people with Parkinson's disease, it can help everybody. Is it going to help people with high likelihood of development of Parkinson's disease to postpone the possible onset of symptoms? We do not know the answer to that question. So, I am offering more questions than answers at the end of this lecture. So, with this we come to the end of this lecture. Thank you very much for your attention.